Thank you, everyone, for joining us today. This is part of our recurring, the Global Health Alliance's recurring event around the Communicators Roundtable. And we're really privileged today to have an incredible organization and some incredible insights from Rebecca Milner, who is the Chief Advancement Officer of International Medical Corps. And IMC is, for those of you that are not familiar, is engaged in some amazing work, which you'll hear about in just a second. And what I think is particularly relevant is that they are not only at the front line of global health in terms of responses to some of the leading and most devastating crises at any one point in time around the world, but they are also able to translate their, for lack of better words, emergency response into enduring change and enduring support into the healthcare system that they are helping develop or evolve. And so unlike many emergency responders within our global health community, IMC really takes this job of healthcare system strengthening and reinventing some of the implementation methodologies associated with healthcare delivery in the most difficult circumstances very, very seriously. And so I think you will find the remarks today very, very compelling in terms of setting a view for the key messaging from a communicator's perspective, but also the key strategies to lead to some enduring change around the world. So without taking any more time, I'm gonna pass the discussions to Rebecca, and our own Megan Battalion will rejoin us at the end of the conversation with some additional remarks. Rebecca, welcome aboard.
Thank you, Mauricio. And thank you to the Washington Global Health Alliance for giving International Medical Corps this opportunity to share a little bit more about our work and some of the emergency responses that we're involved in. I thought I would start, Kayla, if you wouldn't mind going to the first slide, with talking a little bit about sort of the humanitarian conditions writ large across the world. In 2023, 339 million people will require humanitarian assistance and protection. And that is 1 in 23 people around the world, which is kind of hard to imagine. I mean, that's essentially the population of the United States. So what is driving these kind of increasing needs? I mean, this has been growing year over year, and in fact grew by about 60 million people just since 2022. And I think, you know, there's a few factors that are kind of impacting this rise in need. The first, of course, is conflict. According to the World Bank, in 2022, 850 million people were living in countries facing high or medium intensity conflict. And by May 2022, I'm sure you all know very well, as the UN reported, a record 100 million people were forcibly displaced from their homes. And that number is kind of doubled in the last decade. So, you know, for communities in Ukraine, Afghanistan, Syria, Yemen, Ethiopia, and others, these kind of new or long-standing conflicts have wide-reaching consequences for the people who live there. They disrupt health systems and supply chains. They drive an exodus of healthcare workers, increasing food insecurity, and they break down our social and economic systems. So, you know, conflict is a main driver of some of the humanitarian need, but also climate change is, you know, also having an impact. It is linked directly to a rise in weather-related natural disasters and droughts, of course, which then increases pressure on the availability of food, water, healthcare, and other resources. And of course, low-income communities are bearing the brunt of that. For example, today in the Horn of Africa, the Horn of Africa is facing the most severe drought in recent history after 4 consecutive failed rainy seasons. So nearly 36 million people are at risk right now from severe drought. And many of those, facing these severe water shortages and food insecurity in the region, of course, are also impacted by conflict. And then we have the most recent example in Turkey and Syria, where the earthquake killed more than 40,000 people. And we'll talk a little bit about our response to that later. The ongoing conflict in Syria really is made it complicated to deliver assistance. So between climate and conflict, they're driving a lot of the humanitarian need. But at the same time, of course, we all know we're also dealing with disease outbreaks and pandemics. Of course, we were all impacted by COVID. We know the numbers there, killed 6.5 million people, sickened 550 million people, and disrupted every single element of our lives and our work. And it made delivering humanitarian assistance, very complicated. I mean, there were restrictions on movement across borders, and providing aid to those conflict-affected communities was incredibly difficult during the pandemic. But of course, there's also a rise in, more familiar diseases that we all deal with in the global health world, whether it's cholera, measles, or malaria. For example, those disease outbreaks are on the rise and driving a lot of the humanitarian need. We know about the incredible long-lived cholera outbreak in Yemen, that began in 2016, peaked in 2017, but still going on till this day. Syria, in some of the earthquake-affected communities, I mean, they're experiencing a significant cholera outbreak as well. And then, let's don't forget Ebola. The Democratic Republic of Congo has dealt with a series of Ebola outbreaks over the last, since 2018. And, that also has been driving a number of need. And all of that, again, is intersected with conflict. And so that's one of the really main drivers. And of course, as we all know, the pandemic kind of pushed a number of, millions of people back into extreme poverty, and essentially wiped out the gains, the development gains that we had made over the past 20 years, just rolled back the clock. So, the humanitarian needs are increasing across the globe. And, another thing that impacts this and makes it more difficult, next slide, Kayla, please, is the dramatic health worker shortage. So WHO estimates that by 2023 that we globally across the world will be short 18 million critical healthcare workers. And we all know that this, impacts the communities that are in these conflict and natural disaster areas. Just a couple of stats around this. I mean, 84% of people lack access to healthcare in low-income countries. Of course, 90% of the maternal deaths and 80% of stillborns occur in just the 58 countries that lack trained midwives. I mean, the chances of you dying in childbirth are dramatically reduced when you have trained birth attendant. I mean, I think the UNICEF estimates reduces your chance of dying by about 80%. So all of these things are really important, and this is the context in which International Medical Corps works. Kayla, if you move on. So International Medical Corps has sort of led the charge, on these humanitarian crises to save lives and relieve the suffering of those affected by conflict, disaster, and disease. If you go to the next slide. So, like I said, we've been around for almost 40 years. We have over that 40-year period of time, we've operated in about 80 countries around the world. We're currently in 30 countries. A lot of them we'll touch on today. And we have about 8,500 staff around the world. And most of our team members are local to the communities in which they work. In fact, about 97% of our staff in the countries where we have a presence are from the communities, the affected communities themselves. And so we do all that we can to really incorporate the people who have been impacted by these humanitarian crises into our response efforts. If you go to the next slide, we can kind of talk a little bit about the pillars of International Medical Corps and how we talk about ourselves. I mean, to the point about our communicators. I mean, we are a global first responder, and one of our taglines is "First there, no matter where." And I know that this is a big conversation, right? Of course, the affected communities are the first responders, of course. But because we are present in a lot of these humanitarian crises, our team members are some of the first to respond. So, for example, the earthquake in Afghanistan that happened in 2021, International Medical Corps team was there within hours. We sent ambulances. We were operating a trauma care post like right there in Paktika province where the earthquake hit. And so our team was first. And then we also really pride ourselves on trying to go to the hardest hit places and places that are not really easy to reach. And if you talk to my colleagues, and if you look at some of the footage that our colleagues collect from around the world, I mean, we really, try to go to those places where other organizations may not have the resources to get there. And so we really focus on those hardest hit communities. And then, training underpins all that we do. Even in the midst of an emergency, we provide appropriate training, even in the course of responding to the emergency. So it's a dual track. We work on both fronts, and really work to build that, strengthen that capacity that exists at the local level, to ensure that they have the ability to take care of people in their own communities. And I can give you some examples of that as we go through some of the responses. And then, we really, to Mauricio's point, we stay and do our best to help communities recover and rebuild. And really, our kind of big vision for the organization, for our mission, is to restore self-reliance in communities that have been impacted by these humanitarian crises. So we really take that kind of continuum from the emergency phase to self-reliance. And we know that that's not a clear line. It's not an easy path. And sometimes, in countries, especially those that are experiencing conflict, you may take 2 steps forward and 1 step back, but it's really about ensuring that you're really not just kind of addressing immediate needs, but you're simultaneously kind of building for the future, so that there is early recovery efforts start as soon as possible. If we go to the next slide, I thought that what we could do is talk a little bit about some of the emergencies that we're grappling with. And then, please, put any questions that you have in the chat, and we can talk a little bit about, some of the issues that we raise. If we go to, Caleb, the next slide, where conditions on the ground in Turkey and Syria. I mean, it's been all over the news, and I don't think that, I think you all are probably pretty well informed, but, the pair of earthquakes that struck on February 6th, and then the one that came thereafter, was just devastating across an incredibly wide swath of geography, in Turkey and Syria. And I actually was looking at one of the maps, and of course, the epicenter of the earthquake was in Gaziantep in Turkey, but 200 miles away in Syria, a building, a hotel collapsed. I mean, so the sheer kind of geography that has to be covered by this is daunting, and requires the whole community to come together and figure out how we're going to help Turkey and Syria kind of recover from this devastating event. We know the numbers: more than 46,000 have been reported dead, and I think that is definitely undercounted and underreported in Syria. Overall, about 23 million people are in need of humanitarian assistance. Of course, it hit in the middle of winter. People are cold, they've lost their homes, and they've lost their cars and all of their documentation and paperwork. It makes it very, very difficult to respond. And then, of course, in Syria, all of that is complicated by 12 years of war. And so, an already decimated health system really isn't in any shape to care for the people that are in need. And actually, in talking to some of our colleagues in Syria, a lot of the families that were impacted have been, over the past 12 years have moved and moved and moved and moved. And so these are sort of the most vulnerable people. I think that in Turkey, it's a sort of a well-coordinated response. The Turkish government is, exerting a considerable amount of control and, getting things done there. That isn't the case in Syria. It's not. The impacted areas cover both the government-controlled areas and the non-government controlled areas, which then makes it very complicated for responders like International Medical Corps. But we are able to respond. If you'd like to advance the slide, Kayla. Because we've been operational in Syria really since 2008. Interestingly, we were first working there serving Iraqi refugees. I mean, I don't know if anybody remembers, but there were more than 500,000 Iraqi refugees in Syria after the U.S. invasion of Iraq and the subsequent war there. And so, when the war broke out in 2012, International Medical Corps was able to maintain its presence there and continue working there. We have a number of partners that work in non-government controlled areas, and International Medical Corps also works in the government controlled areas. And so we had warehouses in Syria. We were able to immediately release medicines and supplies and distribute them to the functioning health facilities that did exist. We delivered 15 metric tons in that first 3 days, including cholera kits into the Aleppo, Hama, and areas. We have 5 mobile medical units up and running and serving maybe 1,000 patients a week. Our partners in Northwest Syria are sort of managing 8 different facilities. We deployed with our partners, we deployed about 50 community health workers to immediately provide surge support to some of the hospitals that were overwhelmed there. And so, we sort of are now kind of working with our teams. We think that our mobile medical units will remain kind of a core piece of our sort of longer term response efforts, early recovery efforts. And then we will begin working with local authorities to kind of see if we can get these health facilities back up and online, and whether that's rehabilitation, delivering new equipment, supplies, medicines, et cetera. We're just sort of getting organized and trying to figure out what we can do there. In Turkey, we also have a number of local partners, and we're focusing on delivering essential supplies to families that have been impacted by the quake. So whether that is hygiene items, blankets, sleeping bags, tents, et cetera, we're working to get that out the door as quickly as possible. Because meeting people's immediate needs is kind of the way that you can kind of at least begin to take care of them as they kind of wrap their head around this incredible tragedy that's happened to them, and then begin to kind of rebuild from there. So those are some of the highlights and some of the challenges that we're experiencing in Turkey and Syria. Happy at a later time when there's Q&A to talk a little bit more about that. But another response, Kayla, if you move on, of course, is the war in Ukraine. And International Medical Corps also had a presence in Ukraine when on February 24th in 2022, when Russia invaded. So we had been there since the sort of original, conflict flared up in Crimea, right? When Russia annexed Crimea, we were it was a small program. We had sort of had larger operations and then scaled down as time went on. And we had about 30 people in Mariupol. If you remember, that was one of the first cities that was bombed by the Russians. And we're working in Mariupol. Our team and a local partner, we were providing mobile health and mental health services, kind of along that line of contact there. And so, when February 24th hit, if you go to the next slide, Kayla, our first priority was taking care of our staff, finding our staff, making sure they were okay. That took actually several weeks. A number of our colleagues were trapped in Mariupol for 4 weeks or more. We have colleagues that spent all of that time in a basement with dozens of neighbors, no heat, no electricity, running out to cook food and then bringing it back in with children there. But we've eventually managed to reach 27 of our 30 team members and help them get from eastern Ukraine to the west in Lviv. And simultaneous to kind of really making sure our staff was okay, we were sort of scaling up our emergency response efforts. And so, we all know the conditions there, but I guess I would say, the number of people in need of humanitarian assistance in Ukraine is over 17 million, which is essentially 40% of the Ukrainian population. Huge numbers, big scale. And then, of course, as we also know, Russia is bombing civilian infrastructure and particularly health facilities. And I know that you've seen the news, but more than 764 attacks on health infrastructure have been recorded since the beginning of the war. And so, all of this makes it really complicated to respond. But if you move to the next slide, Kayla, we can show a little bit of what we've done over the past year. So as I was saying, we immediately began to use our contacts within the Ministry of Health in Ukraine and ask, how could we immediately be of service? And so medicines and supplies to health facilities was one of the first things that we did. That kind of effort sort of then expanded across the country, and we really have kind of a multi-pronged approach in Ukraine, and it follows kind of the conflict. So in recently liberated areas, International Medical Corps is working with the Ministry of Health to go in, conduct assessments, and begin providing health services and medicines and supplies and things like that for the health sector. But we're also providing what we call non-food items, hygiene kits, and things like that to people that have been under siege for so long. But our strategy on the sort of recently liberated areas, places that were occupied by Russia, it's really about kind of restoring access to healthcare. And so from a health perspective, we are doing rehabilitation, we're delivering medicines and supplies, we're supporting the National Blood Bank, laboratory services, et cetera. And then in places that are kind of potentially on the front lines, like in the south in Odessa, where they could experience a lot of conflict. Our strategy is around helping health facilities harden to make sure that they're prepared for attacks. So one of the things that we discovered, of course, in the early days when the air raid sirens would go off, across the country, hospitals that had ongoing patients in the ICU or whatever, when the air raid sirens would go off, everyone would go down into the basement. And some of the most critically ill people were left alone because they couldn't be moved to the basement. So one of the things that we've been doing is working with health facility or hospitals to move some of their intensive care unit equipment and supplies and things that they need so that they can provide care in the basement so people remain safe. But it's also installing glass doors, covering windows, doing all the things that people need to kind of bolster, and protect health facilities. At the same time, we're conducting training. Again, we've been working with Harvard Humanitarian Initiative with conducting a series of kind of trauma-related training and stop the bleed, working with nurses. I mean, I think if you're a health professional and you're in the primary healthcare space, I mean, it's been a long time since you've applied a tourniquet or dealt with a gunshot wound or whatever. And so doing that kind of refresher training. We also did a series of training around chemical, biological, radiological, and explosive devices. And so there's kind of a whole sort of a training module that we've developed around that. So all of those things are kind of, in those areas that might be hit by Russia. That's kind of our strategy. And then in the sort of calmer areas and the places that haven't experienced direct conflict, we're really working with IDP communities. I mean, we all know that about 7 million people left Ukraine, but another sort of 7 or 8 million of them sort of moved from the east to the west. So there are, a lot of a lot of people have been integrated into the community, but there are also people who had no place to go. So there are shelters there, that take place in schools and other community centers and things like that. So we're making sure that those people have access to health services, non-food items, hygiene supplies, all of those things. And then also kind of a cash assistance program, which is a little outside the health space, but when you're talking about impacted individuals and families, I mean, one of the things that they certainly need is cash, and it's a sort of an unrestricted cash donation to the individual and the family, so they can use it to purchase whatever they may need. And so we've distributed about $3.5 million of cash to about 13,000 people so far this year. So the sort of, we anticipate that the conflict is going to get worse before it gets better. I'm sure you've been reading in the paper, and our colleagues have been reporting an increase in air raid sirens, increase in the bombing, the drone attacks, et cetera. So there's not, I don't think, a great outlook for Ukraine in 2023 from a humanitarian perspective. And we do expect that it will continue to deteriorate in the coming months. So, you look at Ukraine, you look at Syria, Syria 12 years on, we just hope that people will continue to support the, needs in Ukraine. It's, donor fatigue is something that I think we all probably deal with. Anyway, that's kind of a summary of Ukraine. We can go to the next emergency. Okay, Ethiopia. And this is something that probably hasn't been in the news quite as much as some of the other conflicts. But if you go ahead and forward the next slide. As many of you know, in November of 2020, war, sort of a civil war broke out in Ethiopia. And the Tigrayan region, the Tigrayan people, of course, had been in power for many, 4 decades, prior to 2018, when a series of protests across the country kind of forced them out, and a new prime minister was elected, or new government was elected, Prime Minister Abiy, whom you all probably know, early in his, service, in his government service, he won the Nobel Peace Prize for sort of kind of closing that chapter with Eritrea. But shortly thereafter, in November 2020, conflict broke out within the country, and the Tigrayans kind of rose up and took up arms against the Ethiopian government. So the past 2 years have been incredibly challenging in Ethiopia. And it is surprising how little coverage it did get. And part of it is the Ethiopian government. They're incredibly restrictive. They don't allow journalists in. They don't allow groups like us to have cameras, video, any of that. They're very, they keep a tight control on what happens inside Ethiopia. But, those 2 years of conflict were incredibly difficult. And on November 2nd of 2022, a peace agreement was signed, or ceasefire agreement was signed, and sort of active conflict has subsided. We are tentatively hopeful that progress will be made, and humanitarian access will continue to kind of open up, so that we can reach the people in the Tigray region. If you see the dark blue area of the map, was where most of the active conflict was, and that's, there was kind of a complete inability to access that population, which is about 4 million people in need in that area. But of course, Amara and Afar, the two regions or I guess states near Tigray, also were incredibly impacted by the conflict, and multiple kind of ethnic groups got involved. But essentially, more than 14 million people in that northern Ethiopia are in need. And of course, the health system, was sort of decimated across the board. In Hamara, more than 500 health facilities and 1,700 health posts. In Ethiopia, they have, kind of primary healthcare centers, and then they have small health posts where you can go, get a vaccination, or, some kind of antibiotics or treatment for malaria, smaller health posts. But, more than 2,000 of those facilities need to be rehabilitated or renovated. I mean, and they needed to be, they're completely non-functional right now. And so they need to be supported with equipment and supplies to be operational. And, in Afar, the region, right over to the right, to the east, only about 23% of the health facilities in that whole state are functional for a population of more than 2 million people. So, even though the war is over, things are not going to get better for a long time. If you go to the next slide, we can talk a little bit about what International Medical Corps has been doing there. It's required us to really be nimble and to kind of, go where the need is. But we've also had to really care for and ensure, to the extent that we can, the safety and security of our own staff. So, throughout that 2-year period, there were times when we had to move staff members away from active conflict. We had to have evacuation plans. There were, shortages of fuel. We had to ration fuel. Like, do you use this fuel to go reach an IDP population, or do you wait and hold this fuel in case conflict comes to this area and our staff have to get out. I mean, those are very difficult decisions that were being made on a day-to-day, week-to-week basis. You can't get money in. If you can't get cash in, you can't get anything done. Communication was very difficult throughout that whole 2-year period. And we, were sort of operating across that region, across 26 different IDP sites, with a kind of target population of about 800,000 people, really, running mobile medical teams that provided health, mental health, and nutrition services throughout that. Of course, conducting daily delivery of water, any of the kind of community-based hygiene promotion effort, and then medicines and supplies. Right now, humanitarian access is gradually increasing. I do think we'll find incredible need throughout the country. I think Ethiopia is one of those countries that, this conflict has really kind of set them back on those SDGs and the sort of, development gains that they had made. And it's a really, it's going to take a long time to kind of bring everything back. And all of this is sort of coupled with the drought that I spoke about a little bit in the opening remarks. I mean, it's impacted, people. Not only are they on the move because of conflict, but they're on the move because their crops have failed, their livestock have died, and they have nowhere else to go. So, again, while the peace agreement or the ceasefire agreement is a positive, very, very positive development, it's going to take a considerable amount of time to restore health services throughout that region. Tough environment. If we go to the next response, speaking of tough environments, we can talk a little bit about Yemen. If you want to go to the next slide again. Yemen has been experiencing conflict for nearly a decade. An estimated 24 million people, about 2/3 of the population, are in need of some kind of humanitarian assistance. Safe water, access to sanitation services, and healthcare is not existent for a large population of the country. Children are, incredibly impacted by this. Malnutrition is a significant issue across the country. And I mentioned also the cholera outbreak that has had really a devastating impact on communities across the country. And then to the point of, even if the war stopped today and things got better, nearly half of Yemen's health facilities are non-functional right now. So International Medical Corps has been operating in Yemen since 2012, and we really try to provide a multi-sectoral response across the 7 governments that we have a presence in. So we support about 40 different health facilities and 5 different mobile medical teams, and serving about a little over 1 million people. So our health and nutrition, it's integrated, and so of course we're always really looking to identify children that are malnourished, and if we can help them in the early stages of that, it's much easier for them to recover. And so our mobile teams are out there screening, as well as providing health services as they're moving from town to town. Water, sanitation, and hygiene is a huge issue. Again, we do water trucking, but we also, to the extent that we can, try to provide water tanks, ensure that there's water in health facilities, et cetera. And then, food security and livelihoods, it's a big issue. And to the extent that we can, we support that need, particularly in places where we may be one of the few humanitarian organizations that are operating. I mean, of course, our core strength is health, mental health, nutrition, but if, an extension of that really is ensuring that families have the food and the ability to provide the food for their families and some level of livelihood support. So I just, kind of touched on a few of the major emergencies that International Medical Corps is responding to. I thought, maybe we could use the last 15 minutes to answer any questions. And Megan, I don't know where you want to start.
Rebecca, thank you so much for your time today. This has been an incredible conversation, and we really do appreciate your time. Let me just start with a couple of questions. The first ones actually that we have from Maggie Kilborn-Brook. She's a senior program officer at PATH. IMC is described as a first responder for emergencies, but also works with communities to regain skills and tools for self-reliance. Can you talk a bit about the differences between these two roles? Because it seems the roles/activities might differ.
Sure. And I think I touched on this a little bit in the presentation, but it's really sort of considering that humanitarian assistance is also early recovery activities, right? And supporting these health facilities as they kind of emerge from whatever crisis that they're facing. And so ensuring that there's functioning health facilities, that they have water, power, the well-trained staff. We do a lot of training there. In many instances, we're sort of an extension of the Ministry of Health. So we help provide, services. We provide supportive supervision for Ministry of Health staff. Some of those things that maybe the ministry isn't kind of equipped to provide, but we would, ensure that these health facilities have the different medicines and supplies. They're providing the, data back to the, main, ministry and doing all of that, providing the training, that kind of thing. When it's possible, we do, provide health system strengthening. A lot of the places that we're working is, in a more active conflict zone, but we've certainly worked with different hospitals, like say, for example, in Afghanistan, to help, bolster their administrative systems, data and information, those kinds of things. And it really is kind of, it sort of depends on what the needs are. We really try not to set up a parallel system, right? It's not International Medical Corps' health facility or the way that we want to work. We really want to partner with ministries and local authorities to make sure that, we're meeting, the host population's needs. And so, it's not a perfect delineation, but I do think that we really feel that a lot of this can be done even in these emergency contexts where maybe a lot of those development actors aren't comfortable operating in, but we can provide kind of a stopgap measure to help, make sure that there's some level of system strengthening happening even in that time of conflict or crisis.
Yeah, thank you. Maggie's second question is, IMC states it relies on research and evaluation to ensure its response is effective and efficient. Can you give some examples of what IMC has learned through research and evaluation and how this has changed/refined your response and activities?
Yeah, so I'll address the research question a little bit first. I mean, and this is, of course, something that it happens in partnership. And I guess I would say overall, I mean, no one organization can work in a vacuum, right? I mean, it requires all of us, to partner together to get these things done. And so a couple of examples, I would kind of point back to the Ebola. I mean, some of the early Ebola outbreaks where we were running Ebola treatment centers, and we were participating with other organizations that were running Ebola treatment centers and participating in clinical trials for some of the medicines and vaccines that were being developed. And so we were kind of a a participant in that. We also, because we were a major responder both to the West Africa Ebola outbreak and then also in the DRC, we had lots of data that we had collected from that, and we were part of a kind of a Ebola data sharing collective that included MSF and the Wellcome Trust and some of the others. And so, I guess the research component of that is, when we're partnering with some of the members of the broader community. We've done some of that around mental health, partnering with WHO, really to talk about how do you kind of integrate mental health services into primary healthcare setting. And that's been something that we've been working together with WHO over, and we've issued guidance and for other organizations to kind of adapt that. So that's kind of the research component. The evaluation component, it's sort of monitoring, evaluation, accountability, and learning. So that's kind of how we talk about sort of M&E at International Medical Corps. It's sort of MEAL. So monitoring, evaluating. We love our acronyms in the humanity. So from that, it really is kind of an internal reflection on our programs and our progress toward our programs. And so that process takes, it's ongoing, and it's throughout all of our work, and different pieces of that, different pieces of the work each have their kind of own evaluation process. So after any emergency response, we do after action reviews. We really take that whole process quite seriously and really identify weaknesses in our response, places that we have to do better, staff up, et cetera, whatever that might be. From sort of accountability perspective, we, along with other members of the community, are working to really integrate accountability to affected populations into our work, making sure that they're at the center of what we're doing. So we allow patients that have, for example, been to our hospital, to tell us how they felt about the services, what they felt like we could improve on, or designing programs or kind of interventions to make sure that we're surveying, talking to leadership and community members, male and female, both, to really improve those projects. From a also really from sort of the back office piece of it, like from our logistics team, really getting good at ensuring that there aren't stockouts, that we can anticipate, the ebbs and flows of kind of the need for different pharmaceuticals and medicines and supplies that we deliver. I mean, there's a constant kind of review and evaluation of how we're doing on that. Are we experiencing stockouts? Some of the things that we do to do that. So it's multi-layered, and I don't know how well I answered that question, but it's sort of integrated into all that we do.
Sure, absolutely, and that makes perfect sense. It's so many of those aspects of the work that you do are absolutely integrated, and it's important to highlight. So thank you. We have another question that's come in from Chris Pencook, who's from the Association of Public Land Grant Universities. Their question is, who does IMC partner with on food security production issues?
Mm-hmm. I mean, so that's a difficult question to answer kind of quickly and in whole. I mean, it sort of depends on the country, and how much we're involved in sort of the food security livelihood piece of it. I mean, of course, we work with great organizations like Action Against Hunger, and our members of different consortium for responding to those. We take like the nutrition piece, and they take the livelihood and food security piece. When we do kind of livelihood work, it's more smaller scale. Like, for example, in Yemen, the 3,000 kind of households that we worked with to kind of make sure that they had the livestock and training and things that they needed. So and of course we work quite closely with the World Food Program, but that's not the that supply chain kind of commercial aspect of it. So I mean, in so many of the places that we work, I mean, the market's not really mature enough to or it's been broken. So it's not something that we dive deep into.
Sure, absolutely. Another question from Dawn Brazel from Fred Hutch. And their question is, what are exciting innovations in enabling patients to access care?
So I can give you an example actually from the US. I mean, and you might ask, well, why is International Medical Corps responding in the US? I mean, I think we all know that COVID kind of pulled back the veil on some of the weaknesses throughout the US healthcare system. But also, with climate change and the increasing severity and regularity of natural disasters in the United States, we've been responding, we responded to Hurricane Katrina back in 2005, but we've been responding more regularly, essentially since 2017 with Hurricane Maria and Irma. And so, we've recognized that there are, really mostly within low-income communities that don't have great access to quality care. There is a need for increasing access to care. I mean, there are, we talk about food deserts, but there are also healthcare deserts across, the United States. And so one of the things that we've been looking at and working in particular with one of our partners in South Carolina is increasing the use of community healthcare workers with delivering messages, monitoring kind of non-communicable diseases, et cetera. And so I think that that's one way that we are helping increase access to care there. Another way that we're doing that is through some technology solutions that our teams have been working on, where we're better able to manage our pharmaceutical pipeline and ensure that from the point of issuing a purchase requisition to the delivery of the medicine to the patient, that we can track it all the way through. And so that is an exciting innovation in the sense that it reduces the amount of time that patients have to wait. It monitors any adverse drug interactions. It alerts pharmacists if they've prescribed too much, all of those things. And so that is a more rational use of those pharmaceuticals. And that's another one. And then I would say it's not really so innovative, but it is just kind of our way of operating, is partnering with these Ministry of Health, our Ministry of Health colleagues across, and delivering the kinds of training and refresher training that's needed for these sort of underfunded, under-resourced health systems. And so that is something that we're really committed to. It's that whole cliche or old adage around, teaching a man to fish. It's really about ensuring that local people have the knowledge and skills to take care of people in their own community. And so that's all about increasing access to care.
Yeah, and that's both amazing points. And it sounds like the work that you're doing around the pharmaceutical systems, for those of us who've worked directly in the field, know how extremely complicated that is. And so it's wonderful to hear about that. I have a question, which is, could you tell me a little bit more? You touched a bit on climate change and health, and how that's really changing the way a lot of people are now finally starting to come up to speed, and look at what's happening. How is IMC able to potentially get ahead in some of that messaging and help to spread that message that climate change and health are inextricably linked?
Right. Well, I mean, when we talk about the trends driving emergencies, I mean, that's something that we've really begun talking about to the public and really making that case that it is impacting. I mean, I think, we've talked about the kind of increasing size and severity of that, but the overwhelming thing is going to be the heat right? Heat. It's going to, I mean, we've experienced it even in the West, right? With Europe and the United States, and it's going to, you know, really hit these populations, you know, super hard in places that don't have, you know, access to electricity and cooling. So, you know, we're really looking at adaptation. Like, what are the things that we can do to kind of prepare and lessen the impact of climate on the communities that we're working in? We haven't gotten very far. We're really just beginning to grapple with this. I mean, you know, the global community, right? We know the issue. You know, developing the solutions and the sort of how we're going to address them, that's a lot more complicated. And so it is an ongoing conversation within the organization and how we're going to do that. You know, adaptation, we're here. I mean, there is no more mitigation, right? I mean, this is one of the things that we've been kind of talking with and working with different experts around this. The time for mitigation's over. We're going to have, now it's here. We're warming and we're going to have to adapt. And so what does that look like, and what does that look like in really low income communities that are suffering from conflict and, you know, disease outbreaks? And so how do we do that? So we're beginning to kind of pilot some ideas around that. I mean, it's really, you know, right now more facilities based, and like, how do we make facilities you know, withstand the heat, you know, maternity wards, right? You can't have a woman, you know, trying to give birth in a place that's, you know, 100 degrees. So what are those things that we need to do there? And so this is going to be sort of a priority moving forward for the organization, to figure out how we're going to adapt our programs to meet these increasing needs.
Well, thank you so much for touching on that. It's definitely a topic that's quite near and dear to our hearts. So I appreciate that. So with that, I want to say thank you, Rebecca, for sharing your time with us today. We are incredibly grateful for the opportunity to learn more about the work that International Medical is doing in Syria, Turkey, Ukraine, Ethiopia, and Yemen, and the rest of the world. So thank you for joining us. We're also excited to announce that International Medical Corps is one of our first members of the newly announced Innovation Exchange. The exchange was designed to match organizations creating innovative solutions with the funders and investors devoted to creating positive social impact. More information on the exchange can be found on our website by following the link in the chat. For our attendees, we do appreciate your attendance today and want to let you know about some ways you can stay in touch with us. First, you can sign up for WGHA's monthly newsletter, Field Notes, to get the scoop on Washington's global health community. For our member organizations, please let us know if you have any news that you'd like to share. We'd be happy to feature it in an upcoming edition of Field Notes. For those of you who are not WGHA members, we offer pricing options for sponsored posts and Field Notes. And you can always follow us on LinkedIn and Facebook for more updates. For those of you in organizations who are not a member of WGHA and would like more information, please don't hesitate to reach out for additional details. Kayla's added that email in the chat. And finally, I just want to say thank you so much for everyone joining. We're grateful for your continued support of WGHA, for organizations like IMC, and we look forward to connecting with you at our next event. Thank you for joining.